So welcome everyone to our Healthy Minds webinar series. This is the second session in our four-part webinar series about preparing people with severe mental illness for Ramadan, which will focus today on the clinical management for people, and we've got a great lineup of people. The aim of these sessions is to improve the way we deliver our services, to promote better lives and respect the rights of people with severe mental illness. Questions, if you have any, please add them to the chat function or to the Q&A session. And if you see a question that you like, give it a thumbs up. We'll try and answer as many as possible. And please be respectful. So my name's Sasha Batt. I'm the Priority Director for Healthy Minds, and I'll be your host today. I'm joined in the webinar by some esteemed colleagues, and I'll just go through and introduce each of my colleagues, and then you'll hear from them. Dr. Salman Wakar, who's an academic GP and president of the British Islamic Medical Association, who are partnering with us for this series. Salman has been absolutely instrumental to this work and has really helped us drive forward these four webinars. Dr. Sheikh Asim Yusuf, OBE, is an NHS consultant, psychiatrist, Islamic scholar, emeritus chair of the British Board of Scholars and Imams, and awarded an OBE for his services to the Muslim community during COVID. He's very well known nationally and internationally for his work and the author of several books, and really honoured to have him here today. We have Faraz Hussain, who's our principal pharmacist for community mental health teams in Bradford District Care Trust, and Dr. Junaid Azam, who's a GP partner in Bradford and an associate director of primary medical care for our health and care partnership. So I do want to extend a huge thank you to our speakers who are here for this webinar. This is something they're doing over and above their day work. It's a topic that we're all very passionate about, and we want to share the learning, knowledge, and bring people with us on this journey. So just a bit of context as to why you're here, why you're in Bradford and virtually. It's a wonderful city that is really diverse, brings together a huge population of 660,000 people, of which 38% have Muslim heritage, and real important focus for us here. But also when we think about some of the challenges and the assets that we have in Bradford, very much similar to across the country, areas of deprivation, areas of huge assets, but overall a real ambition for us to improve the health and well-being of our communities. And that's what we call our Act as One approach here, where all of our services, our organisations who work and deliver and serve our communities are coming together to improve that ambition. So just a bit of a recap of what we've had to date. The first webinar focused on some background information, why Muslims fast, and we heard from Professor Ghazal Amir, who talked about some of the adaptive services that we've provided for people in Muslim communities. And we had a focus on that general preparation, which we'll hear a lot more in terms of the clinical support today. So that's what the purpose of today will be. As I mentioned, this is a recorded webinar. You can find details of the upcoming webinars, of the past webinar. If you've not had a chance to see that, they're all available at the partnership website, which is down there on the screen below, www.bdcpartnership.co.uk. And there'll be a whole range of resources that we'll be presenting and developing over the course of time, which will be shared there for people to use. The first speaker is going to be Sheikh Asim, who's going to talk to us about why Ramadan is important and give us some background information. And then he will hand over to Dr. Salman Wakar.
Assalamu alaikum. And I'm not sure, it's that time of the day. Do I say good morning or do I say good afternoon? We don't really have a good lunchtime, but good lunchtime anyway. To all of you, and thanks to the hosts who arranged this wonderful series of webinars, which hopefully will be very helpful. I mean, I know it's Bradford based, so I'm from the Midlands, very close to Birmingham. Again, huge Muslim population. These questions come up all the time. Lots of these sorts of questions around fasting, particularly in relation to mental health and so forth. So it's wonderful to be here, and I'll just give you a very quick introduction to these topics. I mean, my part of this, and I'm happy to come in where questions are concerned as well, but really just to have a look at the importance of Ramadan to Muslim to Muslim communities and Muslim patients particularly. Also, the other question that often comes up is the question of capacity, in terms of the capacity that patients have to take decisions. And then, of course, questions, and we have expert pharmacists and so forth here, but questions around medication and what we can do to help patients in those circumstances and scenarios. So happy to chip in where I can. I think most of you will probably be aware of the month of Ramadan, or Ramzan in Urdu, which is the fasting month for Muslims, one of the pillars of the Islamic faith. Most of you will probably have heard of the 5 pillars of Islam. Islam is a bit more than that, but the 5 pillars of Islam. But really, I think this is not so much important from a theological perspective, but rather probably more from where we're coming from a sociological perspective. There are a number of pillars of Islam: prayer, charity, fasting, and the pilgrimage. Of those, what you find is the one that has the most important communal component is the fast of Ramadan. So you may find that there are Muslims who are not practicing in terms perhaps of regular prayers, who are not, and you very unlikely to get into discussions about zakat, about charity, and so forth. But most Muslims will have an eagerness to fast during the month of Ramadan. And the reason for that is that fasting is a social activity. The fast is a dawn to dusk fast. The period that we are moving into, the month of Ramadan, because Muslims work on a lunar calendar, the month of Ramadan moves backwards through the year effectively. So questions about a few, 3, 4, 5 years ago, I was getting lots and lots of questions about the length of the fast in summer. It's sort of from 3 in the morning till 9 at night and so forth. We are very unlikely to have to be that concerned about the questions of the length of the fast. The period that we're moving into this year, or the following year, I should say, and the years after that, the fast is not likely to be longer than about 14 to 16 hours long, and therefore what you may find is that more people are asking questions because they feel that they can fast. The fast is a dawn to dusk fast, but around that you have the opening of the fast, which is breakfast, basically, strangely named. We have 2 breakfasts effectively. There is a break fast when you wake up from your sleep and you have something to eat. That's why breakfast is called breakfast, because you've been fasting through the night. And then we have another break fast, which is in the evening when the sun sets. And both of these two, what's called the sehri and the iftar in Urdu, the opening of the fast, you might say, and the closing of the fast, both associated with food and company. These are really social occasions. So families will get together, communities will get together, people will be passing food around from houses to houses and so forth. And it's something that is that people really look forward to, and therefore may feel that they want to participate in. And this is why it is important to understand not just the theological importance of fasting, but the sociological importance of fasting. So I hope that point is clear. Now, the question, of course, relates to of the abstinence from food and drink for the daylight hours. Amounts really to, there are 2 basic questions. One is questions relating to physical health, and one is questions relating to medication efficacy. So from a physical health perspective, is it safe for the person to abstain from food and drink for that period of time? When you think about, for example, patients on lithium, is there a possibility that they may become dehydrated, push up their lithium levels, and all the very significant complications that can arise because lithium works within a very narrow therapeutic range? Questions relating to metabolic syndrome, if patients on antipsychotics or potentially antidepressants, or just generally because of their poor mental health have developed metabolic syndrome conditions like diabetes. What concerns do we have about management of sugar levels and that sort of instability as well. So these are important questions from a physical health perspective. And then there are questions relating to medication efficacy, and therefore the question of how one goes about delivering care, considering that patients may very well want to engage in the 30-day long fast. This is very important for us to understand as caregivers, whether Muslim or non-Muslim, to understand the theological parameters at a basic level, to understand the medical concerns if there are any, to understand the third pillar, the third angle or vertex of this triangle, which is the patient's wishes and the benefits, the health benefits, mental health benefits that participating in a communal activity can bring. So this is the third element that I wanted to understand, it's important to understand that it is these sorts of communal activities that actually can boost people's recovery, boost people's mental health, because of this fundamental concept of connection. You feel like you are connecting to God, you feel like you are connecting to the community around you. It brings you into, perhaps if you're normally quite isolated, you'll tend to be more social during the month of Ramadan. All of this is extremely beneficial for mental health outside of medication and therapy and so forth. So this is why Ramadan is important to understand. It's going to be March, April this year. So, we're having this seminar in November so that you can start to plan ahead, start to discuss it with patients, see what their thoughts are on the matter, and try to ascertain. And I think Salman is going to go through having a look at a bit of an algorithm or a flow chart to see how one goes about risk assessing, considering both the benefits and the detriments that may arise. So I think I'll leave it at that. That's a bit of an introduction. If anyone has any questions, of course, please do feel free to ask.
Thank you, Sheikh Asim. Sasha, could we have the next slide, please? So Sasha has kindly introduced myself. So I'm Salman, I'm a GP and an academic as well. And with other colleagues, we have put together some guidelines that can help colleagues in addressing both the Ramadan consultation, but also furthermore, how do we address the management issues of patients who are fasting Ramadan. Yes, next slide, please. Thanks. So as Sheikh Asim has said, that there is a strong motivation for people to fast in Ramadan. But it's important to recognize that people, even if they have poor health or seemingly poor health, they may have fasted the month of Ramadan before all throughout their adult life, and have managed to come to some way of adapting, some way of coping, which may not be very obvious to individuals. So the prior experience of individuals is actually incredibly important, and we'll come on to that in a moment. As we've also said, that oral intake is not permitted, and that includes many forms of how medication is taken. Of course, there are some differences of opinion on things like inhaled therapies and suppositories and things of that nature. But in general, for mental health conditions, these tend not to apply. But what is important, and again, we will touch on this later with Faraz, is around the alteration of meal patterns, and also total calorific intake and fluid intake can substantially affect the way that medication is metabolized and absorbed. It's also important to recognize that the fast isn't a binary choice. So it's not that you, as a clinician, when you're talking to a patient, or indeed when the patient is asking you the question, it's about whether you can fast the entire month of Ramadan or not. There are other things that patients can do, such as perhaps fasting a day and seeing how they feel, and then seeing how many more days that they can fast, or to have a fast later in the year. And again, we'll talk about some of those options that could be discussed with patients as part of that shared decision making. And finally, again, as Sheikh also mentioned, we're mainly talking here about adults with capacity. If anyone does not have capacity in general, they are thought to be exempt from fasting. Of course, it is something to bear in mind that some persons, particularly elderly people who have got cognitive impairment, they still may have some understanding that they need to perform the fast, especially due to that socialization element. But from a religious point of view, they would be considered exempt. And it's about how do you have that conversation with them that doesn't make them too distressed, but also equally is not causing them harm from other medication or other issues that may be needing to be addressed for them. Next slide, please. A lot of times people talk about the issue around neurocognitive performance, that is how much the fast might tire you out or cause incidents and accidents. So actually, when if you look at the research, and we published papers around occupational health on this, the issue isn't necessarily linked to the fast in and of itself. The human body is actually very remarkably adept at responding to the poverty of fluid and food. It's actually mainly related to sleep disturbance. And this is quite important, again, particularly in context of severe mental illnesses, where a lot of patients may be on drugs which may sedate or may make them more alert. And alteration of that may have significant impact on the neurocognitive performance, which we wouldn't necessarily know unless the patient has actually given it a go. And therefore, that leads into the important role of acclimatization and preparation. As of today, we are just over 100 days short of Ramadan beginning. And we will talk about later about, and many of you who are familiar with medicines optimizations with these patients will know that these aren't drugs that you can very easily switch on and switch off. There's a lot of work required in titration, in weaning people off medicines and starting them on. And therefore, for these patients, it is incredibly important that if they are looking to consider fasting and they're fasting naive, or if there has been a change in their circumstance, that we do consider acclimatization and preparation, so trial fasts outside of the Ramadan period, to see what that does. And when we're talking about trial fasts, we're actually talking about 2 or 3, possibly more consecutive days of fasting, just to see what that accumulative effect is like. It's also worth mentioning, as I mentioned in the first webinar, that there are significant public health opportunities here. So whilst we may be focused on the biomedical aspect, don't forget the social aspects here, or the other lifestyle intervention opportunities that you have to think about, things like smoking cessation or other substances that may be being misused, weight management, dietary modification, and so on. And as I said, we will talk about some of the alternatives to fasting and exemptions on health grounds that will exist in this presentation and also in the questions. Next slide, please. And as also mentioned in the first webinar, and just to reiterate that as clinicians, we will routinely be taking a harm or risk reduction approach. So again, in this context, people who are accessing drug and alcohol services, for instance, will be undertaking behavior that is deemed to be risky, that is deemed to be harmful, but we still talk to them and still have shared decisions with them to try and get them to take less risky behaviors. And so for people who have got risky issues in respects to their Ramadan, their health and Ramadan, it's important that we are facilitating and still using the same principles that we would use around patient-centeredness and shared decision making. Because in difference to Ramadan, we've seen this all throughout, for many other aspects, indifference to the person's lived experience and what matters to them leads to a further engendering and widening of mistrust. And we've seen the damage that has given to our health and our societies, really, not only from the pandemic, but also much further than that in terms of the inequalities that we experience. And it is entirely possible to give appropriate counselling, especially with people who are not used to fasting themselves, not being from the Muslim community, or perhaps being from the Muslim community and not familiar with this. It's very easy to pick up and to facilitate a safer Ramadan for your patients, and you will find that they'll be incredibly helpful, and you can actually reach out to a population in ways that you haven't been able to do before. Next slide, please. Right, so getting into the nitty-gritty of it now. So when we look at the studies around Ramadan, we have to remember that they are of limited generalizability, and the quality isn't the best, if we're honest. Many of these studies haven't been done relatively recently, so therefore the methodologies of studies and trials and so on hasn't necessarily been up to date, as it were. Many of them are done in a non-Western context as well, so they're done in societies where the timing is different, so we're not looking at long summers that we have here. We're not looking at contexts whereas in many parts of the Muslim world, working hours are reduced to accommodate the fast of Ramadan. And furthermore, life switches to more of a nocturnal society. So people are able to work into the night where they are able to eat and drink. That doesn't happen in Western societies or Muslim minority countries. And so therefore what we see taking place in Pakistan, Bangladesh, Saudi Arabia, Malaysia, Indonesia is perhaps not so transferable to us in Bradford or in the United Kingdom. So what we did during COVID, myself and many other, we had a sort of a team of over 100 people. We did a very rapid evidence synthesis in light of COVID and the fast of Ramadan to understand risk and understand what advice we would give to patients, and we formed expert consensus around that. And we created a shared decision-making framework, which isn't authoritative, but it is quite informative. The decision will always rest with the patient in consultation with the clinician, as a hallmark of a shared decision that's been made. But to help me give more confidence around the work that we've done here, most of the sections that we have written are now actually published in incredible peer-reviewed journals. And if you just go to the next slide, that has the link to the compendium, as it's called, and that QR code will take you to that resource. So I'm just going to quickly go through that. And the other thing, which is the BMJ practice pointer, which is an article that colleagues have written on the basis of that, which actually goes through the basis of how do you advise patients and have that general conversation. And there's a really good infographic in there, which I will also talk about in this presentation as well. So if you click on that link, next slide, please, you'll go to this document. As I said, it's not the most ergonomic document, I should say, rather. But if you click on each link, it will take you into the evidence, what the literature says about it, and then also what our recommendations are in that as well. And it also explains other things like some of the background and so on. Nonetheless, the general principles when it comes to having that consultation. So for you as a clinician, when you're faced with a patient in front of you, do the things that you would do anyway. Take a full medical history and a drug history. These are the two most critical aspects in that consultation. But we must also remember that in that we must also talk about the Ramadan history, if you like, and that involves the previous Ramadan experiences. So how have they coped in the previous years? How were the Ramadans for them? How was their approach to that? How did they prepare for it? Understand what their experiences were. How did they cope? And in addition to that, we need to understand, since that last Ramadan, have there been any changes, not only to their health, but also things like their job and their routine? Have they had a child since then, and they've sort of, been incredibly busy? They're not able to do the normal things that they've done. Have they been made redundant, and therefore they have a lot more time at hand? What's happened to their lifestyle and so on? How stable are they, essentially? And then we have to look ahead at the Ramadan that is coming up, and what plan changes are there? So are they going to be doing a lot more night shifts, for example, as a shift worker? Or have they felt that I'm not sure about my health now? I've seen this and that happen, and their willingness to fast has been somewhat affected. And also, if there is any issues around religious authority that the patient needs to consult, it's also useful to broach on those as well. So to ask the patient that, in preparation for Ramadan, have you thought about discussing with a religious authority? And for many people that won't be an issue, and there are some that will want to do that. And the key thing here is now to then risk stratify the patient. So all of that put into context, we now need to assign a risk to the patient. Next slide, please. And in that document that I mentioned in the compendium, there is this document here, which this flowchart here, excuse me, which gives 3 sieves or 3 outcomes as to what the risk stratification will result in. So first, you need to understand, does the person intend to fast? So you may have someone that says, do you know what, I don't want to fast this year. That's their decision, and that's the end of that. But if they say that I actually do want to fast, we then need to apply that risk stratification to it. And we'll talk about what goes into what risk. But essentially, you're having a traffic light system here of low/moderate risk, high risk, and very high risk. And the reason that we've done it that way is because it mirrors the established literature that exists in the diabetes world, where there are a lot more higher quality trials and randomized controlled trials, and a lot more sort of hard data, if you like, which use this form of categorization. And the reason they put very high risk and high risk is because that captures this concept of people being incredibly motivated to fast and going against medical advice and fasting. So it has a slightly higher tolerance, if you like, for people going against medical advice and giving it a go. So in essence, people in the red category, you would be saying that the advice would be that my clinical advice is that you must not fast. And as in the yellow category, the advice would be that you should not fast. And in the green category, of course, nothing is free from risk, but we would advise that in general that this is fasting that we would deem to be safe, and just some general medication changes would be allowed. In the yellow and red category, we would still, and again, this is, I think, the key thing here, is that we would still offer the patient appropriate advice, and we'll comment to that in a second. And it's important to recognize that a lot of this is based on consensus, so the evidence base isn't particularly robust in the way that we perhaps have it in other clinical guidelines. But this hopefully gives you a hook to hang your hat on, to be able to say to the patient that it's not just I feel that you're not right, you're ready to fast. You're able to appropriate and assign something that is a bit more tangible to them. And that's also something that religious scholars like to hear as well, because they want to hear things in slightly more concrete and categorical terms, as opposed to my doctor thinks. They are able to put something a little bit more concrete, noting that a lot of this is still quite heterogeneous. Next slide, please. So in terms of the different categories I mentioned, in the moderate to low risk, we would just look and seeing if medications need adjusting and reiterate sick day rules, for example, what to do if you are unwell and how to go about it. And if the advice in the high or very high risk category, which is to not fast, is agreeable, then you can reassure the patient, and we can talk about alternatives to Ramadan, which again we'll talk about shortly. However, and this is the common scenario, and this is the issue where this is where all of this comes about really, is if the patient says that, thank you very much, however, I still choose to fast, then you don't just leave it there. I think there's a lot of work that we can still do. And where it is safe and appropriate and indeed practicable, it should be offered to have some degree of monitoring or some degree of follow-up where possible. And of course, to discuss red flags and to tell them when they want to terminate the fast as well. And as I said at the beginning, it's very important that for these patients, before the month of Ramadan begins, that they consider a pre-trial fast to consider acclimatization. And finally, it's really important that we document, and certainly for medical legal purposes, that we have told the patient that in our opinion as clinicians, that this person is very high risk and high risk, and my advice has been that they should or must not fast, depending on the context that's been put there. Next slide, please. So a lot of this data, a lot of this will be in that. So it's very difficult to go into this in sort of 10, 15 minutes. So hopefully they've got something to sort of go back at. This is the infographic in that BMJ paper. And that goes through everything that we've just discussed, where it talks about the history taking, it talks about lifestyle changes, it talks about exploring person's values, and again, their approach to Ramadan, their prior experience, medication, and certainly indeed location as well in climate. As Sheikh Qasim said, we're entering into a cooler period, we're entering into a period where the daylight hours are shorter, and so therefore this will be easier for people. And then at the bottom it talks about that shared decision of what to do, and it also talks about the trial fast. So a lot more data, a lot more information for you to hear, to go away and digest. Next slide, please. In the mental health bit as well, there are some diseases or some disease states rather that we have put into different categories. So you can see here that for the patients who have very high risk of electrolyte imbalances, then we would sort of say that they're very high risk, or those people who have well-controlled mental health illnesses with no relapses in the last 12 months, we put at low risk. There aren't many, if any, papers that are sort of doing these types of research. So if anyone is interested in that, I think there's a huge opportunity here to contribute to a very largely unanswered research question with bona fide primary evidence. Nonetheless, this is what colleagues like Sheikh Qasim and others have contributed towards, to be able to again give you something to hang your hat on. One more slide. I think sorry, this is just very briefly talking about an acute illness. So in the context of mental health illness, this generally is perhaps less applicable, because if someone is feeling acutely unwell, well, I suppose it is applicable. Just consider it both in physical and non-physical. Just ignore COVID-19 for a second on the side there. That's more to do with a communicable disease. It's more about people's ability to break the fast. There is often a reluctance to do so, out of a desire to be, for many reasons that Sheikh Hassan mentioned, but a lot of it is that they don't want to delay, making it fast, or they don't want to be seen as falling short in their religious obligations. But from a religious point of view, and I'm sure Sheikh Hassan will mention as well, that the bar to be breaking the fast, if you are concerned about being ill, is relatively low. And if they are uncertain, they can certainly seek advice from their clinician. But if there's an acute illness, there is dispensation for them to break the fast. And just a final slide for me is in the resources that I've mentioned. There is a paper here in the American Family Physician Journal that we published, which just highlights some of the alternatives to Ramadan fasting, which, as I mentioned earlier, is around trying non-consecutive fasts and fasts before Ramadan to acclimatize. It's also about being able to fast after the month of Ramadan has completed. So often now, for example, where the days are very short, that may be possible in terms of if there's issues to do with timing and the length of the fast. And also for those people who are then unable to fast at all because their condition is such that they are not ever likely to be able to make it up, then they may pay charity in lieu of fasting that year. And if they need to, they can speak to religious authority about that. Thank you very much. Sorry for going a little bit fast and quickly through that, but I'm sure there'll be quite opportunities to ask questions, and I'll just hand over now to Faraz.
Thanks. Before I go ahead, Asim Yusuf's got his hand up.
Yes, thank you. It's just to add to what Dr. Salman mentioned, that often there is this guilt complex, if you like, associated with not fasting or having to break your fast and so forth. And it's obviously we're not expecting any clinician to give a fatwa to the patient, but you know, to give a legal ruling to the patient. But it is worthwhile bearing in mind that the dispensations for illness when it comes to fasting are literally baked into the scripture itself. So in exactly the same place where the Quran discusses the fast, in the very same verse, the exemption from fasting because of an illness is mentioned. So it's worthwhile at that point, you know, mentioning to the patient, if you have those concerns, that they should go and speak to their local to a local scholar about this, and the fact that there are exemptions for illness which are in the Quran itself. Thank you.
Thank you, Sheikh Hassan. Hi. So I'm Faraz, specialist mental health pharmacist at Bradford District Care Trust. So my focus will be pharmacological management. Now I appreciate some of you might not be clinical here, but I think you will appreciate some level of detail so you understand the types of things we are thinking about. And what I've also tried to do is I've tried to intertwine salient points within the presentation. So I've structured it according to medications, because I'm a pharmacist. That's the only way I can think of doing it. But within the presentation, I've tried to intertwine some salient points. So first thing before I start with the presentation is people might be on several psychotropic medications. So they might be on an antipsychotic, they might be on an antidepressant, benzos, and so on. So that adds a layer of complexity. On top of that, they might be on physical health medications. So that adds another layer of complexity. So these are the types of things we need to think about. On top of that, the severity of the physical health condition might be quite bad, or the severity of the mental illness might be quite bad. So physicians, specialists will now need to balance all of these things and come up with an appropriate management plan. So I think what we'll start now. So if you go to the next slide. The primary use of antidepressants, obviously, you've got depression, anxiety spectrum disorders, and bipolar affective disorder. There might be some off-license uses like pain and so on, but these are the predominant uses in mental health. So what types of things would we think about when, if for a patient on an antidepressant? So some antidepressants might be sedating. So your TCAs like amitriptyline and so on might be sedating. So that's something we need to think about, because an individual who's fasting, their sleep-wake cycle is disrupted, the daily routine is disrupted. Sleep is a big issue for people with severe mental illness anyway. So that's something we will think about. So if they're taking, for example, a sedating antidepressant, I might want to time the dose accordingly so that it doesn't affect, you know, them waking up and so on, or a daytime drowsiness. Likewise, the opposite is also true. So some might be alerting. So some might disrupt sleep. And again, I might want to ensure the timing of the dose is managed accordingly. And in order to do that, forward planning is key. It's better if the individual patient or carers let the mental health teams know in advance, a couple of weeks or a month in advance, that I'm thinking of fasting, I'm on these medicines, how will this affect my sleep pattern? And that's something we can incorporate into the treatment plan. With respect to the timing, is not really an issue. Most antidepressants are once a day, so that's fine. A lot of people also have questions around having the medication with food and how that will affect the absorption of the drug. So for antidepressants, that's not usually a concern. Most are once a day. Most, it doesn't matter if you have it with or without food. And to be honest, it doesn't really matter in Ramadan, because whether you take it in the morning or late at night, you'll have it with food anyway. For some drugs, it is important. So, but it's not really. One of the drugs I can think about is an anticoagulant called rivaroxaban. So the absorption of that drug might reduce by 40 or 50% if you don't have it with food. But like I said, with antidepressants, it doesn't really matter. So that's generally antidepressants. Next slide, please. Another class of medication we commonly use are antipsychotics. They're predominantly used for psychosis, schizophrenia, schizoaffective disorders, bipolar affective disorders, major depression, and personality disorders, and they're quite effective if used appropriately. So let's have a think about sort of antipsychotics. So again, like antidepressants, most are quite sedating. So again, a person's sleep-wake cycle will be disrupted anyway because they're fasting. So I might need to fine-tune the dose or the timings of the doses. Unlike most antidepressants, some antipsychotics are given multiple times a day. So might be taken in the morning, midday, and night. So again, forward planning is key. If somebody is on a 3 times daily dose, we might need to rationalize that, maybe split the dose morning and night, for example, and take it from there. Again, some can be alerting. So aripiprazole is a good example. It can affect sleep and cause sleep disturbance. So again, the clinician would think about the timing of that dose. Again, there's minimal dietary requirements, so the effect on the absorption is minimal. But one of the key salient points, I think, with antipsychotics is sort of constipation. So when you're fasting, a lot of people suffer from constipation because the daily daily habits changed. It could be due to reduced caffeine intake and so on. So even a person who's otherwise physically well, especially in the first week of fasting, might suffer from constipation. And that can be particularly problematic with a particular drug called clozapine. So again, that's something we would think about. And there's other psychotropics we use, some antidepressants, especially the sedating antidepressants. Some calming drugs can be constipating because they've got a high anticholinergic burden. And it's particularly important with individuals with SMI because their health literacy might be poor. They might not know how to manage constipation and so on. So again, important safety netting would be key. So I would make sure, for example, if you've got a patient on clozapine who's deciding to fast, what can we do? So I might look at the baseline bowel habit. So if they're going maybe once or twice a day, so let's say they started to fast, now they're going once a week, that's quite concerning for that person. So I'd like to think about that. So bowel habit, constipation, and so on is an important thing. The other thing that's quite important is the hydration and dehydration. Basically, when you're fasting, you're not eating during the day. It can, in some cases, if not managed properly, lead to acute kidney injury and so on. So if a patient's on an antipsychotic, so there's 2, sulpride and amisulpride, for example, we would think about that, because what that can do is it can damage the kidneys and it can lead to high levels of the drug. So constipation, hydration, etc. are types of things we would think about, the timing of doses and so on. So that's antipsychotics. Let's go on to the next slide. The other types of drugs we commonly use are sort of mood stabilizing agents. These agents sometimes are also used for epilepsy. So they're most commonly used for bipolar, major depression, schizoaffective disorder, and self-injurious behaviors. And like our colleagues said earlier, one of the key drugs here would be lithium. Lithium is what we call nephrotoxic, so it can damage the kidneys if not managed properly because it's got a narrow therapeutic index. So again, if you've got a patient who's taking lithium, I would like to think about that well in advance. So maybe I would look at the level of the drug in the body. I would look at the the renal function, the kidneys, is the kidney function okay, and so on. And then I would make a considered decision. And then what we would want to also think about is appropriate safety netting. So good patient education, good carer education. I might counsel them on signs of lithium toxicity. So I might say to the patient, okay, you're fasting, your lithium levels in range, your kidneys are okay, but be mindful if you experience nausea, vomiting, a tremor, etc. It could be due to lithium. And then provide that appropriate safety netting advice. The other thing I could think about is valproates with food, and we may need to review the timings of doses. So that's sort of mood stabilizers. Benzos. So benzodiazepines is a touchy subject, but the predominant use for us is anxiolytics. So they're used for their calming properties. These are a little bit trickier. They can be given multiple times a day. There's a higher risk of withdrawal if the patient stops taking them and so on. So again, we would need to carefully consider, is a patient on a benzodiazepine, how many times a day are they taking it, and can that be rationalized safely, and so on. They're sometimes used in acute situations, but obviously, if a patient needs a benzo in an acute situation, the question is it appropriate for that person to be fasting anyway? So the answer to that would be no. They can also increase falls risks and so on. So that's an important consideration to think about. And we need to factor this in and balance it against the patient's physical health. So that's benzodiazepines. I just got a few more points. I don't have slides for this, but I've spent a considerable amount of time in the inpatient setting at Linfield Mount Hospital. A huge number of our patients are Muslim, and during Ramadan, we've had no major concerns, no serious incidents and so on. And it's usually a very calm period on the ward, and the patients fast. And I can't think of a situation where we've had a major issue. So that's quite good. So those are the sort of main points. So again, each case is assessed on an individual basis. As the colleagues have said before, forward planning is key because it gives an adequate time to reach a shared decision. It gives us time to provide safety netting advice, to counsel the patient and so on, and the carers. And sometimes you might need to make the changes ahead of time, because there might be a reason why a patient is on a dose 3 or 4 times a day. It's better to adjust the doses beforehand, so we have time, maybe a week or two, to monitor response. And that again might give some reassurance that actually it's perfectly reasonable or safe for this patient to fast. So those are the main points, I think salient points for the group, and that's the end of my presentation.
Thank you so much. Thank you to all of our speakers who've shared their knowledge. I'm going to hand over to Junaid, who's going to take us through the Q&A and probably start us off with the first question as well.
Yeah, thanks, Sasha, and thanks to all of our speakers for very useful and practical guidance. I think, especially with the links that you've shared as well. I think we are planning to share the entire webinar afterwards, including the slide deck. But I think there've already been some quite useful links shared in the chat as well. And on that note, if you've got any questions that you'd like me to highlight, either you could raise your hand if you want to speak, or if you, the easiest thing might be just to pop your question in the chat. Just whilst we're waiting, I'll kick us off. I mean, I was speaking previously to all of the speakers sort of in the session planning for this, and I think one of the things that came to my head although it's great to have, the guidance there, I'm just thinking from a jobbing GP perspective, quite often there's a little bit of nervousness around changing medications that are usually initiated by secondary care. So as GPs, we're normally quite confident with things like antidepressants, but normally when it comes to mood stabilization medication, antipsychotics, dementia medications, we'd usually be quite nervous or reluctant about making any significant changes to those medications. So it's really open to the entire panel, really, just sort of what your thoughts would be on that sort of particular dilemma that frontline GPs might have.
So I can come in here. I can't put my camera on for some reason. Sorry, Dr. Yusuf. So I'll come here as a psychiatrist. Yes, it's completely understandable that you would feel reluctant where that type of thing is concerned. Patients who are, I suppose it would depend on the circumstance and the situation, but certainly help should be sought from the secondary care services. I mean, normally there wouldn't need to be much medication change that is required. That's the first thing. Particularly given the period that we're going into, it's much more likely that a patient would, take their medication in the morning at the time of opening the fast, and then take medication at night when the fast ends. If it's a twice daily medication, it would be if a patient required a non-antidepressant, so for example an antipsychotic or a mood stabilizer, to be changed. I think that is probably something that should be referred in good time to secondary care services to be managed there. I would completely understand a GP's reluctance to engage in that, particularly given patients with severe and enduring mental health problems. They can be stable for a very long time and still precariously stable. So, but I think my experience, certainly down here in the Midlands, is that most of those patients would have some access to secondary care anyway. So it may more so be a case of advocating for those patients, with their secondary care team, their RC and so forth. Thanks.
Thank you, Dr. Asim. I think, just thinking about local guidelines and sort of what the local arrangements are, usually most patients are under secondary care. There may be some patients potentially that have been stabilised and discharged to primary care. So maybe those are the ones where we'd need to get an early referral back to secondary care. I mean, it probably links to a wider commissioning discussion, really, in terms of what we've got set up. I remember, Faraz, you were talking previously about a potential upcoming service. Sorry to throw the spotlight on you, but this might be relevant time.
No, I think opening up a referral would be quite a long-winded way of going about it. I mean, that alone might take a few months before anyone sees it. You are free. You can ring. My initial thoughts are to ring Linfield Hospital Pharmacy Department. Try to get through to the pharmacist on duty, because most of the time it's not a matter of changing the dose, it's around the timings. So that's quite straightforward. There's no real issues around that. It becomes more complicated when you're looking at switching the drug or changing the dose of the drug and so on. But the changes we're talking about is timings, it's not the dose. So that should be fine. I give us a ring. Yeah.
Thank you. That's useful. I think we can include that information with the slides when we submit them online later. Did you have any thoughts, Dr. Salman, about anything discussed?
No, I think it kind of brings home the point that we can't have this conversation unless we're having the conversation, right? So if GPs or any other clinician, even non-clinical colleagues aren't asking patients about their intention to fast Ramadan, we're not going to be able to get this richness out from them. And so, as colleagues have said, any timings or adjustments to medication, they do need a little bit of time going into it. And we know that services are stretched as it is, and getting access to timely advice is an issue. So if we are having these conversations with patients, make every opportunity and every contact count. So even if it is well outside the Ramadan window, say it's in the summer and Ramadan is like sort of 11 months away, it would still be highly appropriate to ask a patient if to to ask about the plans for the next year around the fast of Ramadan, and to get that conversation in early. So it doesn't need to be additional work that's put in, with new clinics and things of that nature, if we can have those conversations up front. But the most important thing is to have the conversation.
Yeah, definitely. I think that kind of brings home why we're approaching this webinar series well in advance of Ramadan, so that clinicians can think about gearing up those reviews. And I think as a wider point, and we did talk about this previously, but maybe practices need to get into the habit of arranging almost like an MOT before Ramadan, just to sort of prompt early discussions about these things, because it's not necessarily just about the mental health aspect. There's obviously physical health considerations, and we've spoken at length previously about diabetes in previous years as well. That usually comes up on the radar as well. I'm just looking at the chat. We've had a few questions come through. So apologies if I'm getting the names wrong. So Rika P says, you spoke about making up fasts in the winter months when the duration is less, if that is the issue. If it is known that someone can't fast during the longer periods, can they fast in advance this winter? So I think I'm going to gravitate to you, Dr. Asim, if that's okay, in terms of that specific question.
Yes. So if it is known that someone can't fast for longer periods of time, then one of the options, can they fast in advance? No, they would fast afterwards. They wouldn't fast in advance for technical reasons that I won't get into. But you would make it up in the following period of time. You can't do it beforehand, as it were.
Thank you. That's a very clear answer. And then the second question that came in was about the information being disseminated to carers as well as patients. I think that's fairly easy for us to do. We can just tap into the carer network that we have here locally in Bradford and just make sure that all the information is distributed to that specific network as well.
Probably a good plug for the fourth webinar, which will be about carers, family members, community members. So that will be covered in that. As we build the webinar series, we'll build a good amount of information to disseminate to different audiences.
Thanks, Sasha. Yeah, so that's a good plug for that webinar. I think it probably brings us nicely to a close, given the time as well. So I'll hand back to you, Sasha, just to wrap things up, if that's okay.
Thank you very much, Junaid, and thank you to all our speakers and to all the members who've joined today to listen. As we've mentioned, all the information will be on our website. We will point you to all the tools, resources that both Dr. Salman Wakar and Sheikh Asim Yusuf have mentioned, what they've shared with us today. So the compendium and all the links to that will be shared. And as I mentioned, we'll also be pulling together a whole resource library that will be hosted on the partnership website. We'll also take into account some of the suggestions and ideas that have come up through today's webinar. So, for example, the MOT clinics, that might be something we want to speak to our primary care colleagues about, how we can start to host those if that's a possibility. I just want to draw this to a close. Thank everybody, and thank everyone for joining us, and look forward to seeing you on the third webinar series. Thank you.
Thank you, everyone.
Thank you.
Take care.
Thank you.
Thank you. Bye-bye.